The year was 1847. A U.S. Army surgeon named Josiah Simpson was riding with a small patrol through the Llano Estacado, the great flat tableland of what is now West Texas. They had been in the field for 11 days. 2 soldiers had fever. One had a deep gash along his forearm from a fall on a rocky ledge, and the wound had already turned the wrong color, pale at the edges, with a faint smell that the surgeon recognized and feared. Simpson had trained in Philadelphia. He had textbooks, instruments, a leather case filled with glass bottles and metal tools. He had studied under men who had studied under men in Edinburgh and London. He knew what he was supposed to do. He cleaned the wound with whiskey. He applied a poultice of bread in hot water. He wrapped it tight with linen. 3 days later the wound was worse. Then the patrol made contact with a small group of Comanche traders. The exchange was uneasy but not hostile. And one of the Comanche men, an older figure with a face like carved stone, looked at the soldier's arm without being asked. He said something in his language. A scout translated. He said, "That rap is killing him." What happened over the next 48 hours left Josiah Simpson so unsettled that he wrote about it not once, but 3 times, in his field notes, in a letter to a colleague in Philadelphia, and years later in a short memoir that very few people have ever read. How did people with no formal training, no laboratories, no medical schools, and no germ theory, treat wounds, infections, and illness with results that trained Western doctors could not explain? That is the question this video exists to answer. And the answer is not simple. It is not romantic. It is not magic. It is something much more interesting than any of those things. To understand why frontier doctors were so baffled, you first have to understand what they believed. In the mid-19th century, Western medicine was not what we think of today. Germ theory, the idea that invisible microorganisms cause infection, was not yet accepted. Louis Pasteur was still working. Joseph Lister would not publish his findings on antiseptic surgical technique until 1867. Before that, surgeons in Europe and America operated in street clothes, used bare hands and reused instruments between patients without cleaning them. The leading medical theory of the time was called miasma theory. It held that disease came from bad air, from rotting organic matter, swamps, night air, foul smells. Not from bacteria. Not from contaminated water. From air. This was the framework inside which every trained Western doctor operated. And it was almost entirely wrong. When a soldier got a wound in the field, the standard treatment involved tight bandaging, which trapped moisture and heat, creating perfect conditions for bacterial growth. It involved the use of caustic substances like silver nitrate and mercury compounds that killed tissue as readily as they killed infection. It involved laudanum, a tincture of opium, for pain which reduced the patient's ability to fight illness. The mortality rate from infected battlefield wounds in the Mexican-American War was staggering. Estimates suggest that for every soldier killed in combat during that conflict, 2 died from infection, illness, or the treatment of wounds. 2 to 1. Not from bullets. From what happened after. The doctors were not bad men. They were not stupid men. They were doing exactly what their training told them to do. That is what made the contrast so hard to accept. The frontier, the shifting, violent, extraordinary borderland between expanding American settlement and the indigenous nations of the West, was one of the strangest medical laboratories in human history. You had formally trained surgeons riding alongside indigenous scouts. You had military physicians watching native guides treat injuries in ways that violated every principle they had been taught. You had soldiers who survived infections that should have killed them, and soldiers who died from treatments that were supposed to save them. The records from this period, field journals, military correspondence, personal diaries, and ethnographic accounts, contain dozens of moments where a Western observer witnessed something they could not explain within their framework. Most of them wrote it off as primitive luck. A few of them looked closer. Those few are the reason we know what we know. Here is the thing about indigenous medical knowledge in North America. It was not guesswork. It was not superstition dressed up in ritual. It was the product of thousands of years of careful observation, empirical testing, and accumulated knowledge passed between generations with extraordinary precision. The mechanisms were different. The language was different. The framework, spiritual, relational, ecological, was entirely different from the European one. But the results in many cases were measurably better. Let's start with something specific. Something that can be documented, tested, and verified. Across dozens of native nations, from the Plains tribes to the Pueblo peoples to the tribes of the Pacific Northwest, one plant appeared again and again in wound treatment, Achillea millefolium, commonly known as yarrow. The name Achillea comes from the Greek myth of Achilles, who, according to legend, used the plant to stop the bleeding of his soldiers' wounds. The fact that both ancient Greek tradition and dozens of completely separate North American traditions arrived at the same plant, independently for the same purpose, tells you something important. Yarrow contains several compounds now identified by pharmacologists. Achillean, which reduces bleeding time, flavonoids with demonstrated anti-inflammatory properties, and volatile oils with documented antibacterial activity. Native healers did not know the names of these compounds. They did not need to. They knew that when you packed a fresh wound with yarrow, particularly the leaves chewed or crushed to release the oils, bleeding slowed faster, swelling was reduced, and the wound was less likely to fester. They knew this because they had tested it. Not in laboratories. In the field. Over generations. In the most brutal testing environment imaginable. The actual wounds of actual people, observed over time, compared across cases, with outcomes recorded not in written journals but in oral knowledge systems of extraordinary complexity. When Josiah Simpson, the surgeon we met at the opening, watched the Comanche healer remove the tight linen bandage from his soldier's arm and replace it with a poultice of chewed yarrow leaves and a loose wrapping of soft buckskin, he saw, over the following 2 days, the wound begin to drain cleanly and the discoloration recede. In his field notes he wrote, "I cannot explain the mechanism. But I cannot argue with the result." One of the most consistent principles across dozens of native healing traditions was something that completely contradicted standard Western practice of the time. Wounds should not be sealed tightly. In Western medicine, tight bandaging was considered essential. It was believed to keep out bad air, miasma, and hold the wound closed for faster healing. Native healers, in practice after practice across different nations, did the opposite. They cleaned the wound. They applied plant-based treatments. And then they covered it loosely, sometimes with treated animal skins, sometimes with plant materials, in a way that allowed air circulation. We now know why this works. Anaerobic bacteria, the kind responsible for some of the most dangerous wound infections, including gangrene, cannot survive in oxygenated environments. A tightly bandaged wound is warm, moist, and oxygen-poor, a perfect incubator. A loosely covered wound allows gas exchange. The very thing Western doctors were trying to keep out, air, was one of the things that was keeping patients alive. This single difference in technique may have saved more lives on the frontier than any medicine in a doctor's bag. An Army surgeon named Washington Matthews, who spent years living among the Navajo in the 1870s and 1880s, documented something that repeatedly confused him. In cases of gastrointestinal illness, severe stomach cramping, diarrhea, suspected poisoning, Navajo healers administered a preparation that included finely ground charcoal mixed with water, sometimes combined with specific clays. Matthews found this absurd. He wrote in his notes that he could not understand why a people would feed a sick man dirt and ash. He did not change his mind until decades later, when he read an account of European physicians beginning to experiment with activated charcoal for poisoning cases. We now know that activated charcoal is one of the most effective treatments for many types of poisoning known to medicine. It works through adsorption, binding toxins to its surface and preventing their absorption into the bloodstream. It is still used in emergency rooms today. Specific clays, kaolin in particular, have documented absorbent properties for toxins and bacteria. Kaolin is still used in anti-diarrheal medications. The Navajo healers did not have the word adsorption. They did not need it. They had the outcome. In the late summer of 1858, at Fort Defiance in what is now northeastern Arizona, a young private named Thomas Coyle suffered what the post-surgeon described as a suppurating wound to the upper thigh, a deep puncture, already infected, with red lines beginning to track upward along the leg. Red lines tracking upward from a wound. Any medical professional reading this will recognize what that means. It means septicemia. Blood poisoning. In 1858, without antibiotics, it was almost always fatal. The post-surgeon, a man named Dr. Edmund Bailey, did what he could. He lanced the wound to drain it. He applied a caustic preparation. He administered laudanum for the pain. He wrote in his log that the prognosis was poor. 3 days later Coyle was still alive, but barely. The red lines had climbed another 2 inches. Bailey had quietly told the man's sergeant to prepare a letter to his family. That evening, a Navajo woman who worked as a domestic at the fort approached the post through the servants' entrance. She had heard about the soldier. She brought a bundle wrapped in cloth, dried plants, a small clay pot, a piece of processed animal skin. What happened next was documented by Bailey himself, in a letter he wrote to his brother in Boston 4 months later, when the private was alive and walking. The woman, Bailey never learned her name, first cleaned the wound in a way Bailey had not tried. She used a preparation made from boiled juniper bark, which she applied both inside and around the wound. Then she applied a fresh poultice made from a plant Bailey did not recognize, bound loosely with the soft skin. She returned twice a day for 6 days. By the 4th day the red lines had retreated. By the 8th the wound was granulating, filling with healthy new tissue, in a way that Bailey described as remarkable. He wrote, "I do not know what she put on that wound. I do not know how she knew to do what she did. What I know is that Thomas Coyle is alive, and I am not certain he would be if she had not come." He spent the next several months trying to identify the plants she had used. He was only partially successful. One of them, he eventually determined, was a species of echinacea, a plant now known to have significant immunomodulatory properties and some antibacterial activity. The other plant he never identified with certainty. It was not just plants. The plants were extraordinary. But what made native healing so effective on the frontier went far beyond any single ingredient. It was a system. And the system had several principles that Western medicine of the time lacked almost entirely. Principle 1. The wound is not the problem. Western medicine in the 1800s treated the wound as the problem. Native healing traditions across many nations treated the wound as a symptom of a broader disruption. In the body, in the person's relationship to their environment, in their strength. This sounds philosophical. But it had intensely practical consequences. A healer treating a wound was also assessing the patient's overall condition. Their fever, their breathing, whether they were drinking water, whether they were eating, how they were sleeping. Treatment was holistic in the literal sense. It addressed the whole person, not just the injury. This meant that a native healer working on an infected wound would also be managing the patient's hydration, critical for fighting infection, and their nutrition and their rest. Western surgeons in the field were focused on the wound. The healer was managing a system. Principle 2. Cleanliness came first. Long before germ theory, many native healing traditions operated with practices that functioned as infection control, without that language. The Apache, the Navajo, the Comanche, and dozens of other nations had consistent practices around the handling of wounds that involved the use of specific plants with cleaning properties before any other treatment was applied. Among the Lakota, wounds were cleaned with preparations from plants now known to contain thymol and carvacrol, the same compounds in thyme and oregano that give them their antibacterial properties. These were not used by accident. They were selected, prepared, and applied in specific sequences. A military surgeon traveling without any preparation, working in field conditions, might clean a wound with whiskey if he had it, and whiskey does have some antibacterial property. But he was not systematically applying plant compounds with documented antimicrobial activity, in the right concentration, to the right surfaces in the right sequence. The healer was. Principle 3. The knowledge was tested. Here is something that almost never appears in popular accounts of indigenous medicine, and it should. This knowledge was not static. It was not simply inherited and repeated unchanged. It was tested, refined, and corrected over generations. The oral traditions that carried medical knowledge across native nations were not passive. They were active records of what worked and what did not. When a treatment failed repeatedly, it was modified or abandoned. When a new plant proved effective, it was incorporated. When one healer found a better preparation method, that method spread. The testing happened over a time scale that Western medicine of the 1800s could not match. Not years, not decades, but centuries and in some cases millennia. The failures had been filtered out long before any frontier surgeon arrived to observe the results. What he saw was not a first draft. It was a very late revision. The surgery question. One place where Western medicine genuinely had an advantage in this period was major surgery, particularly amputation and the repair of complex fractures. Most native healing traditions did not perform deep surgical intervention in the way Western medicine did. Amputation in particular was not a common practice. This had mixed consequences. On one side, native patients were not subjected to the catastrophically high mortality rates of amputation in this era. Infection from surgery itself killed a large proportion of those who went under the knife. Avoiding surgery meant avoiding that risk. On the other side, severe traumatic injuries to limbs that could not be treated without surgical intervention were often fatal or resulted in permanent disability. This is the nuance. Not magic versus medicine. Not one tradition better than another in every circumstance. But two very different bodies of knowledge, each with genuine strengths and genuine limits, meeting on a frontier that needed both. The exceptions. Most frontier doctors maintained a polite contempt for what they called Indian medicine. A few did not. Washington Matthews, who spent 2 decades as an army surgeon in the Southwest, became one of the most serious early documenters of Navajo healing practices. His ethnographic work, done in parallel with his medical duties, preserved knowledge that might otherwise have been entirely lost. He was not uncritical. He noted practices he considered harmful, ineffective, or dangerous. But he was rigorous. He distinguished between things he could explain and things he could not. He did not explain away what he witnessed. A military physician named John Gregory Burke traveled with General George Crook's campaigns through Apache territory in the 1870s and 1880s. Burke was a compulsive note-taker, one of the great documenters of frontier life. His accounts of Apache healing practices are among the most detailed first-hand records from the period. Burke documented the Apache use of specific mineral-rich springs for wound-soaking waters with high concentrations of sulfur and other minerals. He documented the use of pine pitch as a wound sealant, a substance that has since been shown to have genuine antimicrobial properties. He documented sweat-based treatments used for fever management that, in their underlying mechanism, operated on the same principle as the fever-breaking strategies that would later become standard in Western medicine. He also documented his own skepticism, clearly and honestly, alongside his documentation of outcomes he could not dismiss. That combination, skepticism and honesty about outcomes, is exactly what good medicine looks like. The woman they never named. In the records of the frontier, there are dozens of accounts like the one from Fort Defiance. A native healer, almost always a woman in many nations, treats a patient that Western medicine has given up on, and achieves a result that the observing doctor records with undisguised astonishment. Almost none of these women are named in the historical record. They are referred to as an Indian woman, a Navajo healer, an old squaw. Their knowledge is documented. Their names are not. This is not a small point. It means that the knowledge was recognized, at least by the honest observers, as real and effective. But the person who held it was not recognized as a practitioner in any formal sense. She could save a man's life with knowledge that took a lifetime to acquire. She could not be credited for it. That gap, between the recognition of the knowledge and the recognition of the person, is one of the saddest features of this history. When the laboratories finally looked. Beginning in the late 20th century, ethnobotanists, pharmacologists, and medical researchers began systematically studying the plant-based treatments documented in historical accounts and in the surviving oral traditions of native nations. What they found was not what many of them expected. A landmark study published in the Journal of Ethnopharmacology examined over 200 plant species documented as wound treatments across North American indigenous traditions. More than 60% of those species showed documented antimicrobial activity in laboratory testing. Roughly 30% showed significant anti-inflammatory properties. A smaller but notable subset showed activity against specific bacteria commonly responsible for wound infection. 60%. Not a few. Not a handful. The majority. This was not because every plant that grows near a wound has medicinal properties. It was because the selection had already been done. Thousands of years of field testing had filtered out the plants that did not work. What researchers were examining was not a random sample of the flora. It was a curated pharmacopoeia. Yarrow confirmed antimicrobial and hemostatic activity. Echinacea documented immunomodulatory effects. Juniper bark preparations, antibacterial compounds identified. Pine pitch, antimicrobial properties confirmed. Certain clay preparations demonstrated toxin binding capacity. Not all practices held up under scrutiny. Some did not. That is expected and it is honest. What matters is that the proportion that did was far higher than coincidence could explain. The aspirin story. One of the clearest examples of the pipeline from indigenous knowledge to modern medicine is the story of aspirin. Salicin, the compound from which aspirin was eventually synthesized, comes from the bark of willow trees. And the use of willow bark preparations for pain, fever, and inflammation was documented across indigenous traditions in North America, Europe, and Asia, independently, across cultures that had no contact with each other. When European chemists finally isolated salicin in the 1820s and began the work that would lead to acetylsalicylic acid, aspirin, they were not discovering something new. They were catching up to something very old. The synthetic version was more controllable, more consistent, more easily produced. Those are genuine advantages. But the underlying knowledge, that willow bark compounds reduce pain and fever, had been in use for thousands of years before the first chemist looked at it under a microscope. This pattern, indigenous knowledge confirmed and refined by modern analysis, appears again and again across medicinal plants. What Simpson finally wrote. We began with Josiah Simpson, the Army surgeon riding through West Texas in 1847, watching a Comanche healer tell him that his bandage was killing his patient. Simpson spent the next 20 years of his life thinking about that moment. In his memoir, written late in life, published in a small edition that almost no one read, he described what he came to believe. He wrote that the great mistake he and his colleagues had made was not a lack of intelligence. It was a lack of humility. They had arrived on the frontier with a framework that told them what could and could not be true. And when they saw things that did not fit the framework, they adjusted the observation, not the framework. He wrote, "The man who looks at the world only through what he was taught will always be surprised by what he finds. The man who was taught by the world has fewer surprises. He does not need the word for what he knows. He has already seen it work." Simpson never stopped practicing Western medicine. He did not abandon his training or his instruments. But in his last years he began collecting plant specimens and asking questions of the native scouts and guides he encountered. He filled 4 notebooks. They have not been found. What this means? The story of indigenous healing on the American frontier is not a story about magic versus medicine. It is not a story about one tradition being superior to another in every way. It is a story about knowledge, about how it is built, how it is transmitted, and how catastrophically easy it is to lose. The native nations of North America developed medical knowledge over thousands of years through a process of careful observation, empirical testing, and oral transmission so precise that the outcomes, in many cases, exceeded what the most formally trained doctors of the 19th century could achieve with the tools they carried. Not because they were magic, because they were paying attention, in a very specific way over a very long time, to the particular world they lived in. That kind of knowledge does not appear in textbooks. It does not come with credentials or laboratories or institutional recognition. It comes from watching, from testing, from asking what actually happened, not what the theory said should happen, and from passing what you learn to the next person with enough precision that it survives. In the summer of 1876, a cavalry officer named Lieutenant Charles Gatewood was traveling through Arizona with an Apache scout named Alchesy, a man who would later receive the Medal of Honor for his service, and who is remembered today as one of the most skilled scouts the U.S. Army ever employed. One afternoon, a trooper in their party was thrown from his horse. He hit the ground hard, and when they reached him, his forearm was bent at an angle that left no doubt. Compound fracture. Bone visible. Blood soaking through the sleeve. Gatewood reached for his medical kit. Alchesy was already moving. He had the trooper's arm stabilized before Gatewood had his bag open. The splint was improvised from 2 pieces of wood stripped from a nearby shrub and bound with strips of soft material. The wound was cleaned with a preparation Alchesy produced from a small pouch he carried. Something ground, something dried, mixed quickly with water from his canteen. It took him 4 minutes. Gatewood, who had spent 4 years in medical training, stood and watched. Later that night he wrote in his journal, "I have been trying to think of what I would have added to what he did. I cannot think of anything." The trooper made it back to the fort. The arm healed. He was back in service within 8 weeks. Alchesy never received credit as a medic. He was listed in the records as a scout. But somewhere in the oral tradition of his people was the knowledge that had saved that man's life. Knowledge that had been built over generations, tested in the hardest possible conditions, and carried forward with care that no textbook could fully contain. If any part of this story stayed with you, whether it was the wound that should not have healed, the plants that the laboratories finally confirmed, the surgeon who filled 4 notebooks that were never found, or the scout who moved faster than the doctor, write it below. Because the things that stay with us are the things worth talking about. And this is a conversation that has barely started.